Welcome to Cardio-Flash College, a place to learn cardiology with flash animations. Today, we will talk about a very complex topic which we have been improvising and learning day after day. Today, we are talking about the cardiovascular complications of COVID-19. And for that, we count with the collaboration of Dr. Héctor García Prado, clinical cardiologist of the Hospital Universitario Río Ortega. Join us. As you know, the term COVID-19 is an acronym that stands for Coronavirus Disease 2019, and it basically refers to an infectious disease caused by a single-stranded RNA virus, SARS-CoV-2, identified for the first time at Wuhan, China, by the end of 2019. It is currently the cause of this pandemic that has paralyzed the entire world since March 2020. By the time this video was edited, May 2020, it has been estimated that more than 5 million people in the world have been infected by the SARS-CoV-2, and that 300,000 of them have died because of the infection. In this context, Spain has been one of the most affected countries by this crisis, reaching 280,000 infected and 27,000 deaths, which stands for a fatality rate of 10% approximately. This situation has put health systems of the whole world in check. In this way, COVID-19 has had a great impact in every level of health assistance. Some examples are a collapse in emergency services, hospitalization plans and ICUs, improvised creation and restructuring of hospitals and health spaces specially dedicated to the care of COVID patients, redistribution of material and human resources for the care of COVID patients, many times with the detriment of other coexisting health problems, and the beginning of an elevated number of clinical studies, action protocols, and experimental procedures with the intention of achieving an answer to the more worrisome clinical and epidemiological problems of the disease. This has generated a lot of medical literature, but with low level of evidence. For these motives, there is a lot we ignore. However, we can say it seems it has a zoonotic origin, and that person-to-person transmission is carried out by respiratory droplets expelled with cough, sneeze, breathing, or even talking. Most frequent symptoms are fever, cough, tiredness, but some patients can develop pneumonia or severe acute respiratory syndrome that sometimes can suppose death, being especially vulnerable the older patients with high cardiovascular risk or previous cardiopathy. This is why we have asked ourselves, what are the cardiovascular repercussions of this infection? The answer is absolutely interesting for you. Let's take a look. After initial respiratory exposure, virus particles contact with the alveolo-capillary membrane. There, the S protein of the virus couples with the angiotensin-converting enzyme 2. This enzyme mainly expresses on plasmatic membrane of type 2 pneumocytes, but also, secondarily, on macrophages, endothelial cells, and other extrapulmonary cells, such as cardiomyocytes or gastrointestinal cells too. After incorporation of protein complex to the interior of the cell, viral replication, and finally liberation of millions of copies to extracellular space produce, resulting in a direct cytopathic effect to the infected cell, which triggers activation of alveolar macrophages and ultimately cellular apoptosis. Macrophages and other antigen-presenting cells liberate cytokines and activate T lymphocytes. Direct cytopathic effect caused by these lymphocytes, natural killer cells, destroys type 2 pneumocytes and also the rest of the components of the alveolo-capillary membrane. Acute coronary syndromes. This can be the result of a set of macrovascular and microvascular phenomena that are produced as a consequence of the infection and the destruction of endothelial cells by the virus and the immune system. These phenomena can generate endothelial dysfunction and can configure a systemic prothrombotic state that ultimately can cause instability of atheroma plaques. Heart failure. This can happen as a result of the infection and destruction of myocardial tissue due to direct action of the virus and the immune system, configuring a clinical picture known as acute myocarditis. However, ventricular dysfunction can also have an ischemic trigger or can be due to an increase of the right ventricle afterload in patients with compromised respiratory situation. Ventricular tachyarrhythmias and sudden death. This currently is one of the most feared cardiovascular complications. They can happen as a consequence of myocardial necrosis, ischemia, hydroelectrolytic disorders such as hypokalemia, or the acquired long QT syndromes in relation with the prolonged treatment with hydroxychloroquine, azithromycin, and other antiviral drugs. Pulmonary thromboembolism. It can be the result of the prothrombotic state generated by endothelial dysfunction, systemic inflammatory response, and prolonged immobilization of patients during infection and recovery. Alterations of the renin-angiotensin-aldosterone system. Considering that the ACE2 receptor is used by the virus, it seems logic that COVID-19 could develop cardiovascular problems in patients with hypertension treated with ACE inhibitors or ARBs. Because of this, some authors initially recommended the suspension of these drugs since it was probable that pharmacological inhibition of the enzyme could stimulate an increased expression by cells, which would facilitate virus couple. However, there are some disagreements with these, because some studies suggest the opposite, theorizing a possible protecting effect of these drugs. In any way, nothing has been clearly demonstrated in practice, and seizing these drugs in patients with well-controlled hypertension currently seems more dangerous than keeping medication. For such reason, many scientific societies, including the European Society of Cardiology, recommend avoiding suspension of ACE inhibitors and ARBs. Well, now that we understand the pathophysiology of the most frequent cardiovascular problems associated with the disease, we only need to know what to do with the patient. First thing is first, diagnosing the disease. As usual, we need clinical and epidemiologic data from the patient, as well as laboratory tests, which currently are ELISA and PCR. The first one tries to detect antibodies or antigens in a blood sample. The second one tries to detect viral RNA sequences in a nasopharyngeal swab sample. These tests are increasingly accessible to society, but they are not perfect because of having a not negligible percentage of false positives or negatives. For these motives, case definition have been stratified in this way. Confirmed case, which refers to a person with a positive lab test independently of the symptoms. Probable case, which refers to people with clinical or epidemiologic data very suggestive of COVID-19, but with inconclusive lab tests or that they could not be performed yet. Suspected case, which refers to patients with fever and backgrounds of traveling to zones of risk or having contact with COVID-positive patients in the 14 days prior to the beginning of the symptoms, or simply patients hospitalized for acute respiratory insufficiency without clear trigger. Finally, negative case, which refers to asymptomatic people that, after being or having contact with COVID patients, currently having two negative PCR with a separation interval of 48 hours at least, though in some cases, depending on centers and its protocols, just one negative PCR would be necessary if the patient has no typical clinical nor epidemiologic profile of a COVID patient. Now that we know how to define a COVID-19 case, we need to know how to protect ourselves, because the risk of infection is too high between health professionals. In general features and independently of protocols of each hospital, there are three levels of biological protection. The first one is the most basic one and includes the work uniform, latex gloves, disposable surgical mask, and disposable cap. This allows us to serve negative cases or patients with low clinical epidemiological risk. The second level is more demanding because surgical masks are exchanged for protection masks, N95 or FFP2. Moreover, latex gloves are exchanged for disposable surgical gloves and adds extra protection with a surgical gown and goggles. This level of protection is perfect for serving suspected, probable, or confirmed cases that must also carry their own surgical mask. This is the regular protection on emergency departments, hospitalization plans, cardiovascular imaging labs, and cath labs. Finally, the third level of protection is reserved for ICUs and care procedures that leave personnel exposed to respiratory secretions, body fluids, and aerosol sprays of the patient. This includes, besides previous measures, the use of FFP3 masks and full-face respiratory protective devices. Great! Now we know how to define a COVID-19 case and how to protect ourselves during the exercise of our care functions. We also know that the infection of this virus can trigger severe cardiovascular complications. So, are you ready to serve our patients? Yes, probably. But before, we need to ask ourselves, what is the role of a cardiologist during this pandemic? To answer this question, we offer you our decalogue of recommendations. Temporarily suspend outpatient care and promote the use of telemedicine with the intention of keeping close contact with patients. Postpone elective diagnostic or therapeutic interventions in patients with chronic and stable ischemic heart disease or any other cardiopathy with the intention of minimizing risk of infection. If any procedure is necessary, limit personal access and choose among options the ones with the lowest exposure risk. Support more affected care services by the crisis, for example, emergency room, ICUs, internal medicine, and pneumology. Identify patients with high risk of suffering cardiovascular events that could be directly related or not with COVID-19. Choose the most adequate reperfusion strategy in patients with ST segment elevation myocardial infarction, assuming that every patient is COVID positive until proven otherwise, being mandatory the realization of lab tests for confirming or discarding the infection. This must be done as soon as possible without delaying the reperfusion strategy while waiting for the result. Stratify the risk of cardiovascular complications of admitted patients with non-ST segment elevation myocardial infarction and opt for a conservative management in patients with low risk. If cardiac catheterization is necessary, delay the procedure until lab tests for detection of SARS-CoV-2 are made. Discard myocarditis in patients with acute heart failure episodes and keep telemedicine contact with chronic and stable heart failure patients to avoid disarrangement of medications or episodes of clinical decompensation. Keep an eye on the QT interval in patients that are being treated with antiviral drugs such as hydroxychloroquine and azithromycin because the risk of ventricular arrhythmias increase in patients with prolonged Q interval, heart failure, hypokalemia, hypomagnesemia, bradyarrhythmias, and concomitant treatments with antiarrhythmic drugs such as sotalol. For these motives, we need to avoid that the corrected QT interval surpasses 500 milliseconds, guaranteeing, among others, adequate potassium levels, which are more than 4.5, while we simultaneously avoid drug interactions or bradyarrhythmias. There is no recommendation on changing medication in those patients with well-controlled hypertension and treated with ACE inhibitors or ARBs because there is not enough clinical evidence that demonstrates an increased risk of infection of SARS-CoV-2 in these cases. Adjust the treatment of chronic anticoagulated patients because some of these drugs could be contraindicated in patients that are being treated with concomitant antivirals. Moreover, in patients without previous indication of anticoagulation, the use of low molecular weight heparin is recommended in order to avoid thromboembolic phenomena. To conclude, not everything is pulmonary pathology with COVID-19, because this pandemic has generated an increase of mortality by cardiovascular causes as a direct consequence of the infection and by the disruption of healthcare chain. Although many publications exist, truth is that clinical evidence is not quite solid nowadays. What is clear is that assuring adequate protection for health personnel is necessary because the risk of infection is elevated and regular cardiovascular problems such as acute coronary syndromes and heart failure are still present in clinical practice. Finally, it is necessary to remind the relevance of looking out for the proarrhythmic potential of some drug interactions and regular clinical conditions in COVID-19 patients. In this way we say goodbye. It has been all for today in Cardio College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye!